Φίλες και αγαπητοί φίλοι, μπαίνουμε στην τρίτη μέρα του συνεδρίου και την τελευταία, μία μέρα η οποία θα μας δώσει πολλές άλλες ενδιαφέρουσες πληροφορίες για πάρα πολλά θέματα σημαντικά, και ένα από τα σημαντικά θέματα για τα οποία βρισκόμαστε εδώ και το οποίο δεν είναι και πολύ γνωστό στο ευρύ κοινό της ειδικότητας, αλλά πάντα είναι επίκαιρο για εμάς τους επεμβατικούς πνευμονολόγους και αξίζει να το συζητήσουμε, είναι τι συμβαίνει στην χρόνια αποφρακτική πνευμονοπάθεια και ιδίως στον φαινότυπο του πνευμονικού εμφυσήματος, όταν αυτός πλέον δεν μπορεί να το διαχειριστούμε με τη συνήθεια αγωγή, με την αποκατάσταση, με τη φυσιοθεραπεία, με τα φάρμακα, και όταν ο άνθρωπος έχει κακή ποιότητα ζωής και πλέον δεν έχει και πολλά περιθώρια να επιβιώσει με την νόσο του. Σε αυτές τις περιπτώσεις υπάρχει η λύση της θεραπείας της υπερδιάτασης μέσα από την ενδοβροχική τοποθέτηση βαλβίδων, που είναι και το πιο σημαντικό κομμάτι της επεμβατικής τεχνικής, και θα δώσω το λόγο τώρα στην καθηγήτρια, στην κυρία Αντωνίου, η οποία να πει και το καλωσόρισμα σαν συμπρόεδρό μου και να συστήσει και την ομιλήτρια.
Σας ευχαριστώ πολύ. Καλησπέρα σε όλους. Μάλλον καλημέρα, είμαστε πριν τις 12. Και έχω τη χαρά και την τιμή να είμαι ξανά φέτος μαζί σας στη Θεσσαλονίκη. Κύριε Πρόεδρε, πραγματικά εντυπωσιακό το συνέδριο και χαίρομαι. Το πρόγραμμα είναι πάρα πολύ ωραίο και δραδιαστικό. Και è un onore e un piacere per noi di avere a questa sessione la direttrice dell'ospedale di Brescia, la dottoressa Michela Bezzi. Lei è molto famosa in Italia, ha fatto pure all'ospedale Careggi d'Italia, certo, ha fatto tante letture e lei è esperta alle malattie respiratorie con trattamento intervenistico, e allora ci parlerà Michela. Αυτό που ήθελα να πω είναι ότι είναι ειδικός στην επεμβατική πνευμονολογία και ιδιαίτερα θα μας μιλήσει σήμερα για το Endobronchial Lung Volume Reduction στο pulmonary emphysema και είναι διευθύντρια στο νοσοκομείο της Μπρέσα, όπου παλαιότερα είχε πάει και ο κύριος Τιτόπουλος στο Careggi Hospital στη Φλωρεντία, όταν ήταν και στην Μπρέσα και ήταν μαζί φίλοι και συνάδελφοι. Allora è un onore e un piacere di averla con noi questa mattina. Cara Michela.
I can't continue in Italian, I think. I think I'm the only one who's understanding what our colleague says. Thank you so much for this kind invitation. I'm really happy to be here in Thessaloniki for your national conference. I think everyone in the room knows about endoscopic lung volume reduction, but the reason why Dr. Iraklis asked me to speak about patient selection is that probably that's a thing which is evolving over time, day by day, week by week in our hospitals. The more we treat patients and the more we can understand which is the best patient for this kind of treatment. And that doesn't mean the number of patients is going to be smaller and smaller because we select them better and better, but we are also trying to find a solution for more patients with different inclusion criteria. So we are becoming more precise, but we are also opening more options for more patients. Well, when we started, I was really much younger. I was very young. It was like 15 years ago. And we wrote this editorial with Professor Noppen from Brussels. I was practicing. I was working for 1 year in Brussels as well. And it's tough to make predictions, especially about the future. And it's always like that, but especially for bronchoscopic lung volume reduction, because when we started with using valves, I remember we were placing valves in patients with emphysema. We were trying to treat the most diseased part of the lung, but we didn't really know which patient could benefit or not. So we did have some very well-structured, randomized controlled trials, also blinded trials with a control arm and a treatment arm, and we could realize which patients were responding to treatment and why not. And if I think of those days in Brussels, and if I think of what we know now, what we know today, I understand how supporting research in this field has really changed our patient life. So please, join the team. I know you are doing your first treatments in Greece as well, and please put more numbers in these numbers. These are only some of the great publications in the field. What we have learned is that it's a group project. You cannot start alone. Start with your thoracic surgeons. There is one in the room who is really nice. They are not all like him, but you have to start with your thoracic surgeon as well, and your lung function team, and your IP, of course, team, and with the rehab centers and with patient associations. Start all together around this table where you have different people cooking for the best dinner. You can use different tools for that. You have valves, 2 different kinds of valves. Spiration, now sold by Olympus, so it's called Spiration Valve System by Olympus. And then you have the Zephyr valve by Pulmonx. But we also went through other technologies like coils and aerosil and vapor, and we have somehow taken what was good from each of these technologies, and we are trying to put all of them together to answer the need of the most of our patients. That doesn't mean we have a solution for every patient, of course. We still need to select them, and we shouldn't use these technologies when we don't know them or when we are not sure that that's the right patient for that technology. So, we are not God, but we are trying to. Bronchoscopic lung volume reduction, the principle is, of course, to reduce the lung volume, as you can see in these pictures, from a very big, hyperinflated, destroyed lobe to a small atelectatic lobe, which is not occupying so much space in the room of heart and lungs, which is creating a lot of consequences on our respiratory function and also on our heart function. So the idea is to reduce the lung volume to make our respiratory mechanics work better. It can be done, of course, with surgery. Bulectomy is a perfect example of how reducing hyperinflation in the lungs can work and make your patient feel better. Lung volume reduction surgery is where everything started, and of course lung transplantation is not an option for every single patient, but that's the solution for emphysema. When you cannot perform lung transplantation and you don't have a bulla, lung volume reduction surgery can be very useful in removing the most destroyed parts of the lung. But it has some requirements. It doesn't fit for every single patient, but it does have magnificent results. So our question, the reason why we are here today is that we have been looking for a lung volume reduction surgery without surgery for 20 years now. And it has been a bronchoscopic lung volume reduction evolution. In the last 20 years, we've had the first prototype of valve, the bronchus valve you see on the left side, vapor, aerosil, coils, and the most recent valves, as you can see here. And it's been evolving from a very simple technology without many knowledge to what is today actually a very well-known kind of treatment with very precise indications, and it's actually part of our routine treatments in most of the European countries. It's, of course, thanks to all of these publications we've had in the last 20 years. We have this chart where we can choose the right patient for the right tool. Not all of those tools are still available. We don't have airway bypasses anymore. We are really looking forward to having this device back, and I really hope we can work on that as well, because it's very useful for homogeneous emphysema. But at the moment, we can rely on some other tools like Zephyr valves. In this video, you can see how we can measure the bronchi with the light blue line there for the depth, and with the wings, the light blue wings on the left side for the diameter of the valve we are going to choose, because we have two different sizes of valves for the Zephyr valves. And there you have seen real time how we can put a valve in the bronchi, and then we see the mouth of the valve opening and closing. It's a Heimlich valve. It can allow air from the lung outside to deflate the lobe, and it doesn't allow air to go back into the lobe. That's why we achieve an atelectasis when collateral ventilation is not there. It's a very, very quick procedure, as you can see. So you immediately understand that the most difficult part of this treatment is not putting valves in the bronchi. The most important part is to select the right patient for that. So this is the atelectasis. This is all about reducing lung volume, and this is what we aim at. And we have learned how it is possible, of course, in the NET trial, the surgical trial, when we performed surgical volume reduction, we could only treat bilateral upper lobe emphysema. But then in the VEN trial, we started treating also lower lobes. And then we performed the Chartis study, and we understood what is the most important, the absence of collateral ventilation, but we are going to speak about that in a few seconds. And then the Believers trial, and the Stelvio trial, and the Impact study, and all the trials which came along taught us about the fact that we can treat both upper and lower lobe, homogeneous and heterogeneous emphysema, and patients with different characteristics. This has been probably the most important revolution in this field. I remember when we treated our first patients, the only thing we could do was to put valves in the bronchi, referring to the most diseased part of the lobe, and then we should wait for atelectasis to come. Probably 3 patients out of 10 could achieve an atelectasis in that way. Then we started selecting lobes with the Chartis system, with the balloon system, which is actually measuring collateral ventilation, and we started putting valves only in those patients who didn't have collateral ventilation. And that did work, but you can imagine that we have patients coming up from everywhere in Italy, very far from our hospitals in Florence before, and in Brescia, close to Milan now. And you know, you have these patients coming over with their families, because they are most of the time quite old patients, not always. And they are very, very looking forward to improving their quality of life. So they perform a rehabilitation for 3 weeks, which is very important. And then they perform lung function, and they have to respect some inclusion criteria. They have a CT scan, and we study the CT scan. And until a few years ago, we went to a bronchoscopy in general anesthesia. We performed the Chartis to make sure that there was no collateral ventilation. And in case collateral ventilation was there, we had to wake up our patient and say, no valves, no treatment. And that was really disappointing for our patients, but we didn't know before. We couldn't know before. Now we can. Thanks to this Stratex platform, or to any other, this is the one we use and the one we know better, but there are many other semi-automatic analysis of the CT scan platforms. And you can use the one you have in your hospital, or you can adhere to this platform, the Stratex. We capture the CT scan, we send it for analysis, and a few days later you have your report saying that the most diseased part of the lung, in this case, is the black part, so the upper lobes. And then it gives very, very important information about the Fisher completeness score. That's the number you see on the right side. It's 96.7 for the left upper lobe. And it's 75 for the left lower lobe, the dorsal density. And the upper lobe density is, left upper is 75, left lower is 54, and the fissure integrity score is 96.7. That means the fissure is very likely to be complete. That patient doesn't have collateral ventilation on the left side, on the left lung, and you can deflate the left upper lobe, which is the most destroyed. It also gives you some numbers about the volume of the lobe, so you can also choose the most hyperinflated lobe. The most hyperinflated, the most destroyed with a complete fissure is the target of your treatment. Of course, you do rely on STRATEX analysis, but you do perform your Chartis anyway. And this is the proof of the absence of collateral ventilation when you perform your Chartis analysis. You see the flow going down little by little right here, and the pressure becoming more and more negative, and the resistance is going up. And it only took 4 minutes to understand that that patient can respond to treatment with valves. And this is what we do. This is the Chartis balloon. You inflate your balloon inside the lobar bronchus, and you can follow the lines like here. If you have a patient like this with a consistent flow, with same pressure and no augmentation in resistances, that means that despite closing the lobar lobe, you still have air coming out of the lobe. That means the air is coming from the lower lobe or the upper lobe, the adjacent lobe. So there is collateral ventilation. This is not a patient, not a lobe for valves. But if you have something like this, with the flow going down and the pressure becoming more and more negative and the resistance going up, that's the Chartis representation of an atelectasis. The lobe is deflating very quickly in 3 or 4 minutes, and you can put valves there to keep it closed. So Chartis system is crucial. Now we have put together the STRATEX analysis with the Chartis system. And whenever a patient has a fissure completeness score at STRATEX lower than 80%, they don't make the trip to Brescia. They are not patients for valves. They can rely on rehab or whatever kind of inhalers or oxygen treatment, but don't try valves for that patient unless it's in a different clinical trial I'm going to show you in a few minutes. But if the patient fissure completeness score is between 80 and 100, there you can perform your Chartis, make sure that you have don't have collateral ventilation, and put valves. If the fissure completeness score is higher than 95, then you don't need to do your Chartis, just put valves, because there you have a correlation of 100% between fissure completeness score higher than 95 and CV negative at Chartis. So where are we now? What do we do now? First of all, when you see a patient in your clinic, you have to make sure that he is a COPD patient, of course, based on lung function, but you make sure that that's the kind of COPD that responds to valves, so the emphysema variant. It has to be the predominant component of the disease. That doesn't mean the patient doesn't have chronic bronchitis, but emphysema has to be there. It has to be a severe emphysema, so you have to have your FEV1 lower than 50, and you need to have a huge hyperinflation because you want to deflate the lung. So residual volume has to be higher than 180%. It's better if it's a heterogeneous emphysema, but we can also treat homogeneous patients. And of course, your patient has to be able to undergo a bronchoscopy. That's why we always send the patients to a rehab center before the treatment, not only to undergo the bronchoscopy, but also to be able to face the most common complication of bronchoscopic lung volume reduction with valves, which is pneumothorax. In routine practice, it happens about 20% of the times. Doesn't mean you have to put a chest drain in 2 patients out of 8. Probably 35% of the patients need a chest drain based on the literature and on our experience. And then you can remove the chest drain 2 or 3 days later when the air leak stops. But the patient has to be in hospital for at least 2 nights to make sure it's well managed in case it happens, because it normally happens in the very first day of the procedure or the following day. So FEV1 needs to be between 15 and 50% predicted. Gold stage 3 or 4 emphysema with or without respiratory insufficiency. And of course, emphysema has to be confirmed by high-resolution CT scan, which is the one you can send for STRATEX analysis. The residual volume has to be higher than 150, 175, 180, depending on which trial we are referring to. But of course, the higher, the better. The more the patient is hyperinflated, the more he will benefit when you deflate the lung. And of course, we come to collateral ventilation. For valves, little or no collateral ventilation from the adjacent lobe is crucial for treatment. All of these contraindications have been a little bit considered in the last 15 years. Alpha-1 deficiency is a very good indication nowadays for bronchoscopic lung volume reduction with valves, because this emphysema is very heterogeneous, and these patients tend to have a complete fissure all the time. It affects lower lobes. Those are the biggest lobe in the lung, and it's very, very useful for patients with alpha-1 deficiency, the treatment with valves. TLCO lower than 20% is not an absolute contraindication anymore. You can perform a good treatment and have an improvement also in TLCO. Previous thoracotomy or lung resection was a contraindication in most trials, of course, because it's difficult to have a hyperinflated lung if it has already been reduced by surgeons. But sometimes you still have a very high residual volume despite surgery, maybe 20 or 15 years earlier. So that can be a good patient if it's still there, hyperinflation. Bronchiectasis is the real contraindication. That's chronic bronchitis that brings infection to the valve. So if it's a clinically meaningful bronchiectatic patient, you should never consider those patients for valves. But if you see a few bronchiectasis on the CT scan and the patient doesn't have any sputum, he's not symptomatic for his bronchiectasis, that doesn't mean you cannot treat the patient if he has emphysema as well. Severe pulmonary hypertension has been treated with valves, and it has responded with a lowering of the values of pulmonary hypertension, so it's not a contraindication anymore. Unstable comorbidities and active smoking is, of course, something you should never treat with any technology. So, as you can see, the contraindications are becoming less and less. And what do you need? We said we need a lung function test, and you have to perform your lung function with a plethysmography spirometry, because you need to measure the residual volume with the proper technique. The CT scan has to be a 1 millimeter CT scan for analysis of the fissures. Chest X-ray is always useful, even baseline, even if you already have a CT scan, because you are not going to perform a CT scan every week to your patient, and you want to compare the results after valves to the baseline chest X-ray. So never forget that, or you will, regret. And the perfusion scan is also very useful, and we know why. So this is an upper lobe predominant emphysema, and we can see the fissures here on the CT scan. The lung scan is confirming that the upper part of the lungs are not perfused, so we can cut it off without any reduction in lung function. That's the most. And after all I said, you understand that when I was much younger, a young lady of 29 years, and I was speaking about this, everyone was like, it's a placebo effect. You go there, they are desperate patients, you are so nice, and you speak to them, and you promise all they have been dreaming of for years. Of course, they will follow you and they will say that they feel better. But that's not because of valves. That's because you are promising like miracles. But nowadays, we know it's not like that. The placebo effect can be there, of course, depending on how nice you are to your patients, because they go to rehab, they do a lot of gym, and that's really helpful. Probably they take their inhalers more than before because they really believe in what they are doing, but we have an improved survival with valves when we achieve an atelectasis. And it's there in these two papers and also in this one. So you can improve the survival rate of your patients when you select the right patient for the right tool. Never forget about that. So what should we do if our patient came to Brescia and he is CV positive? Nowadays, we have an answer for these patients. It's a clinical trial, and it has stopped enrollment only 3 days ago, on the 23rd of May. It's the CONVERT trial, and it's a fissure closer with the AirSeal system with the foams for converting collateral ventilation status in patients with severe emphysema. It's a multi-center prospective trial. It's taking place in many sites in Europe and in the States and in Australia. So I'm listing here all of the colleagues which have been very, very active in the last 2 years, during COVID even. We had 1,200 patients hospitalized with COVID in our hospital, but we always had our small pulmonary department, which was kept clean for these patients with emphysema and any other pulmonary condition which was not COVID. And so this is meant for patients who have a completeness, a fissure completeness score lower than 100, so they are CV positive, but the gap in the fissure is not bigger than 20%. So we are treating those gaps with AirSeal, with the you know about this foam for emphysema treatment, and we close the gap. 6 weeks later, we go there, we repeat the chartis, and we make sure that collateral ventilation is not there anymore, and then we can put valves. So this is the study design. The primary objective is to evaluate the utility of the AirSeal to close the gap in the fissure, actually. So the AirSeal endpoint is the percentage of patients who converted from CV positive to CV negative status. And the Zephyr valve endpoint is, of course, to achieve lung volume reduction, treating these patients with a new fissure after the treatment. We have a very precise selection and treatment of the target lobe. We can go to the right bronchus with the right amount of AirSeal for the right percentage of the fissure gap in the right place. So it's been evolving in the last 2 years, and it's evolving more and more in the next few months during the summer for the next trial. This is the results from our first 40 patients treated. Now we have achieved 140 patients, so the results will probably come not for these years, ERS, I'm not confident with that, but for sure for the ATS next year. And you see, these are the same patients I listed before. RV was 230% as a median value, TLC 130, FEV1 was, so it's not here actually, where is that? Yes, 32%, sorry. And we treated both left upper lobe, right upper lobe, left lower, and right lower. So every single lobe could be treated. And 50% of the patient had a homogeneous emphysema, and 50% of the patient had a heterogeneous emphysema. So it can be a good treatment for both kind of emphysema. And we were able, this is something I'm really proud of because I've been dreaming about this. I remember I was in London in January 20th, and I convinced Narinder Sharjeel to start with this trial when we were at Pallav course. And we had almost 80% conversion rate. That means that not all of the patients who were not eligible for valves, but at least 80% of them were recuperated to treatment thanks to this treatment. The study has stopped enrollment last week, so we are going through the next steps with the last patients, and we will soon present the results. But what is most important is that we could achieve a proper lung volume reduction of 1 liter and 100 mL in medium, as a medium volume. Of course, we do have adverse events. The good thing is that we do have pneumothoraxes, as we used to have in clinical practice, and it's there, but we almost never experience the chemical pneumonitis we used to experience with Aerosil alone. That's because we are using a very low amount of Aerosil to close the gap instead of spreading the foam in the lung. This is one of our patients in the CONVERT trial, and you can see how he could respond after an atelectasis of the right upper lobe, thanks to the closing of the fissure gap with the valves. This was published before by our colleague Inge from Australia. He was treating the very, very first patients outside of the trial. And yes, it has an acceptable profile, and it does work. So, in case you have patients like these, I really hope Greece will be part of what's coming next, and that's the CONVERT 2 trial. We are addressing the same kind of patients, but only with heterogeneous emphysema in this new trial. We already had the ethics approval, but we are only starting enrollment in September because we are finishing CONVERT 1 first. And in this trial, the only difference with the CONVERT 1 is that homogeneous emphysema is not included, and that we are not treating the right lower lobe. All the rest is very similar. So, thank you for your attention till now. This is a picture from my city, and speaking about Brescia, if I can take one more minute, Dr. Iraklis will be there in 2 weeks for the first International Congress on Robotic-Assisted Bronchoscopy and Transbronchial Ablation Update. That's going to be from the 17th to the 15th of the 17th of June. And it's going to speak only about robotic bronchoscopy and its application together with the ablation technologies. It's endorsed by the World Association of Bronchology, and I think 50% of the scientific board is in this room today, with Professor Kevin Lau from London, and Stefano Gasparini is also here with us today. Dr. Iraklis is coming to represent Greece with some of our colleagues from here. And then Mike Pritchett and Eric Falk and Douglas Kyle-Hogarth are our colleagues from the States who already have a long experience with robotic bronchoscopy because they started 2 years ago. And of course, you know Professor Pallav Shah and Professor Felix Serre from London and from Heidelberg. So please check our website for an updated program, and if you are interested, you can register there, roboticrab.com. Thank you.
Grazie a te. Thank you so much for the excellent talk. I think you have convinced all of us about the safety and the very good results of this technique. And all the best for the good results of your study. And I think that it is a paradigm of how we have to move in respiratory medicine, but also in medicine, with randomized controlled trials, with trials, and with new techniques. However, I'm sure that you have a placebo effect to your patients because you are so nice, and you know, I think the patients need also this encouragement, especially for these, let's say, techniques which are, they are fragile, they have comorbidities, and they need our holistic approach. Michele, I would like to ask you a short question. Maybe it is not a good question, but I think that we have, of course, as you said, bronchiectasis, too much bronchiectasis, etc., is not a very good selection. We don't do the technique, but we have a lot of patients with predominant emphysema who also have in the lower part of lower pulmonary field the pulmonary fibrosis. Could you let us know how you evaluate these patients? Because their DLCO a lot of times are more than 30%, and they need of something more, as antifibrotics, are not enough to those patients.
Yeah, thank you for your question.
But usually those patients have heterogeneous emphysema, or centrilobular or panlobular, different. So, your expert opinion?
Yeah, thank you for your question. I literally skip those patients. I don't like speaking about that because that has been the worst experience with bronchoscopic lung volume reduction I had. I can remember very well the patient, where he was from and his family and everything. We decided to try to reduce the hyperinflation of the lung, which was predominant compared to the restrictive pattern of the fibrosis, but that's really not useful for those patients. So if when dealing with bronchiectasis, you have like a range of severity, you can choose. And if it's a severe bronchiectasis, you should better treat bronchiectasis and then see what remains. When fibrosis is there, send the patient to the ILD team and do not never consider him for valves.
Thank you. We have a lot of participants online, more than 50, and it is very promising that in this specific topic we have a lot of audience, and I will conclude with giving the final word to Dr. Titopoulos.
Many congrats, Michaela, for your excellent presentation. I would like to ask you something. Don't you think that we should take into account the condition of the adjacent to the target lobe? Because we need the hyperinflation of the adjacent lobe, and how we can estimate that it could be done after the procedure.
Yeah, thank you for your question. It's really interesting. We've been studying the conditions of the adjacent lobe when dealing with the reason why we have pneumothorax. Of course, if you have an emphysematous lobe, it doesn't mean that the rest of the lung is like safe and 100% density score. So starting with the CT scan and with the STRATEX analysis, you immediately have an indication about the condition of the adjacent lobe. And that's why in some cases valves are good only for heterogeneous emphysema, which means you should have at least 15% difference between the, let's say, the upper and the lower lobe when you're treating the upper lobe. And that's one of the inclusion criteria in the CONVERT-2 trial. So when you are dealing with heterogeneous emphysema, the results are much better, of course. And the reason why is that you reduce the hyperinflation adjacent to a lobe which can still work and which can still take his place in the chest and work properly. But once we knew that was good for heterogeneous emphysema, we started treating homogeneous as well. And there probably the mechanism of improvement are different, like diaphragm shaping or muscle activation. So you have different kind of mechanism which can make your patient improve anyway, even if the adjacent lobe is not so safe. And you can experience pneumothoraxis there because of the emphysema in the adjacent lobe, but it has been demonstrated in the trials I've shown before very quickly that the improvement of the patient, the results are much better than at least the risk you have with this treatment in these patients.
Okay, thank you very much. Any question for the audience? Dr. Fragoglu.
Thank you for your excellent presentation. Something very new for us. I wonder if you have experience with coils and if you can compare the results of using coils instead of valves, or what are your thoughts about these two methods? Thank you so much.
Thank you for your question. Yes, we do have a long experience with lung volume reduction coils as well. We've been part of the ELEVATE trial, which stopped a few years ago. And coils are not commercially available anymore today. Probably they are coming back, at least two kinds of coils, a little bit different from what we were used to. But in the trials, we demonstrated that coils were really useful for patients with severe, very severe homogeneous emphysema with a very high hyperinflation score. They needed to have a residual volume higher than 200%. But that was the only option for many years for patients with collateral ventilation, and they could treat both lungs. So I don't know if anybody knows about coils. It's like a nitinol coil, which is released into the lung parenchyma, and it retracts the lungs, the lobes, towards the hilum, making the lobe smaller, so reducing the volume of the lobes and lung hyperinflation. And it's a non-reversible technique, and that made some worries in our colleagues. I don't think whenever it's working, I'm not sure you should really think if it's reversible or not, because I don't remember of taking one valve out any day, because when you choose the right patient for the right tool, for the right technology, then the patient is happy with that and it can keep it in his lungs. We only remove valves when it's coughed out by the patient because it displaces, but it only happens in very, very few patients, like 3%. So coils were there. I really hope they are coming back because they are really useful for homogeneous emphysema with a very high hyperinflation score.
Any other question? And the last question for me. I think that you are working at the public sector, okay? What about the cost of the whole procedure?
Well, again, that's not...
it is paid from the patient or from...
Yeah, that's not what we are really focusing on, because that's the hospital administration. I think they made their considerations, and if you think of this very severely healed patient, they come to the emergencies every now and then with a COPD exacerbation. They stay in hospital for many, many, many days with not very good results, and then they go to the rehab centers, but they stay in bed because they can't go to the gym, because they can't walk, and they go to the ICU sometimes because of a severe respiratory insufficiency. So if I were one of those administrators, and if I could put together the cost of the technology and the cost of these patients without any treatment, not speaking about the human perspective, only speaking about cost, it's much cheaper than what we spend every day for any other need. And the valves, of course, are a medical device. There's a lot of research behind these devices, and that's why sometimes they are considered to be quite expensive. But you know, they have been there for 20 years now, and the costs have lowered, and I think it's more than acceptable.
Okay. Thank you very much. Τελειώσαμε όλοι. Thank you very much, Michela. Thank you very much. We're finished.
Thank you all.